Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
All right. Well, welcome to this conversation about new medicines, the rare diseases that are being treated by them, and what that means for our policy conversations, both at the state and federal level. My name is DJ Wilson, one of the folks who is working here at State of Reform to try to tee up these conversations, these policy conversations, but those that are informed and which impact the marketplace, and with trying to create a safe table with left, right, public, private, all kinds of voices in the mix. And we're super excited to be teeing up this one today. I want to jump right in. I'll talk about logistics here in a second, but first I want to introduce our guests today. We've got some great ones. Cheryl Larson is the president and CEO of the Midwest Business Group on Health. Robert Popovian is senior fellow at Health Policy at the Progressive Policy Institute. And Laura Minzer is the president for Illinois Life and Health Insurance Council. Thank you guys all for making time to be with us. Robert, let me start with you, sir. Give us a rundown of the work that you're doing and where you're spending your mental energy these days.
My mental energy for the last few years actually has been spent how to reduce out-of-pocket costs for patients and allow them to afford the medicines that they desperately need to take. And in addition, as an economist, because I'm both a pharmacist and an economist, is to be able to find ways to remove misaligned incentives in the marketplace that forces patients to take more expensive medicines and pay higher out-of-pocket costs unnecessarily. So those are the two things. And really, at the end of the day, it's to really help patients, healthcare professionals, and employers, because they're the true payers in the marketplace and the government to get it right.
Good stuff. Cheryl at the Midwest Business Group on Health. What are you spending your mental energy on these days?
Well, and as Robert just said, in our world, employers are the real payers of healthcare. It's not the health plans, it's not the PBMs, it's fully and self-insured employers. Yet we have little to no say on pricing and contracting for both the medical and pharmacy side. So we focus a lot of our efforts on looking at waste, inappropriate, unnecessary care, low value care on both the medical and pharmacy side. We do a lot of work on the specialty and gene therapy side. I'll share a little bit about that with the results of our survey today. But when they say what keeps employers up at night, which we often have as a title of one of our things, that's an example, and there's many more.
Good stuff. And Laura from the Life and Health Insurance Council, how about you? What are you spending your mental energy on?
I think very much in line with what Robert and Cheryl have also proposed, which is that, it is about addressing healthcare costs. And from my perspective, our members not only serve the large self-insured employers, they also serve the smaller employers as well as the individual and family markets. So it's a lot of unique dynamics from a payer perspective. And I would also add, I don't represent that piece of it, but many of them serve the Medicaid and the public payer perspective. So it is managing from the insurance side is how do you manage the diversity of healthcare needs with the needs of the few versus the needs of the many, and how do you reduce costs in the system across the board, not just when it comes to medications, but healthcare costs in general, which obviously drives healthier outcomes and more effective use and streamline of our delivery system.
Certainly, health reform is a national topic, but we at State Reform focus at the state level, and that's why you got some of the smartest folks working in Illinois and Midwest health reform here today. So I want to just sort of underscore that this is meant to be an interactive conversation. We have about 120 folks registered to be with us today, and so on the right of your screen, you'll see under the Q&A box there's room for you to post your questions, and then there's a little thumb up that you can click to upvote and prioritize those. So I will try to integrate those questions into our conversation as things develop. The idea of this conversation is to use the tools of our modern digital pandemic-informed space to use slides and some graphics and to tee those up visually and then wrestle those to the ground in conversation, like I say, across these silos. So we have 5 slides. for this conversation today. 3 of those are brought by our 3 guests, or one slide per guest each, and then 2 have been teed up by me and our team here at State of Reform. So this first slide I want to turn to is one that we've brought into the fold, and this just gives you a sense, if you look carefully at how things break down, it gives you a sense of the where new medicines are coming from, where they are in the process of being launched, whether they're in the clinical stages. And you can see there's a significant increase of cell and gene therapy. There's a significant amount of monoclonal antibody therapies coming to market. These more complex molecule and larger molecule, and in some cases, of course, very personalized medicines are highly specific, impactful of rare for at the individual level and for rare disease populations in many cases. And generally speaking, in healthcare, the more specific you get, the more expensive you get. So the miracles of these new drugs, and they are miracles, it's amazing the science that's happening, have to be balanced, as Laura just and Cheryl both just sort of spoke to, the sort of individual good versus the common good in a system like ours, where we pay for healthcare from just 2 places, either tax dollars or premium dollars. So with that teed up, Cheryl, let me ask you, when you think about some of these specialized medicines that are coming, how is your excitement and hopefulness balanced by the reality that these are going to be pretty expensive?
Well, we are excited about game changer drugs that are going to improve health and productivity and quality of life for employees and their family members. We are very concerned about the high-cost gene therapies in the pipeline right now because they are more expensive than the specialty and biologic drugs we've seen in the past, some very expensive, a number of orphan and rare disease drugs, and employers are still trying to figure out how the heck they're going to pay for them, and they haven't been given guidance other than maybe vendor or consultant guidance to spread the cost over time or spread it across the entire population. And of course, we're not certain that the vendors out there, stop loss carriers, are going to be able to cover some of these. So in the end, it could mean that some employers will have to make tough decisions about whether or not to cover them. So we're trying to educate and look at all of the options. In a perfect world, we'd get the waste and misuse and inappropriate fees out of the PBM's hands and get the drug manufacturers to work directly with us, which, you know, no one wants to talk about, and do some outcomes-based contracting. And certainly performance-based contracting on the PBM side as well.
Robert, you're a health policy fellow now. You mentioned being a pharmacist and an economist. For a long time, you were at one of those pharmaceutical companies that Cheryl just spoke to. What are your thoughts on how to manage the risk or consider a payment for these drugs as they come online?
So I have to tell you, I agree with Cheryl. We need a different payment model in this in the healthcare system for these new cell and gene therapies, because some of these therapies are going to be life-changing. You're going to be able to treat hemophilia, which is going to be a lifetime treatment for a patient, or you're going to be able to treat muscular dystrophy. But in my opinion, looking at the landscape of who pays for healthcare, which is the patient, the employer, the government, none of the 3 should be taking on the risk, and nor should the insurers, frankly, because these things are going to be for life. And I'm sort of an outlier, and I believe that there needs to be a new insurance product that's underwritten by the pharma companies, and they need to procure the risk for these products. Because if you think about it, if somebody who has hemophilia from birth, the entity that will be with that person who gets that gene or cell therapy is the pharmaceutical industry. They will continue to their life until they pass away, and that therapy needs to be managed and accounted for, and make sure that it's, as Cheryl said, that there are some outcomes related to it. I don't think the government, nor the employer, nor the patient, nor the insurer should be taking on that risk. It should be the pharma company, and there needs to be a new insurance product that is underwritten by the pharmaceutical industry, specifically in these spaces.
So what does that look like from where the rubber meets the road? If the pharma industry should create their own insurance product, that have to happen, of course, in 50 states with 50 state regimes to regulate that. Are you saying that I mean, that would be a very expensive product if they were only insuring the highest cost products. Yeah.
But that's the thing. I mean, it's a rare cases that these drugs will be used. So it's very easy to, first of all, make sure that the patient's on them. And it only will be used in entities, large entities that can do it. But the underwriting part, it has to be done by the risk has to be taken by the pharma company in this case. I don't see why would an insurance company where or an employer where the patient is only with them for a limited period of time, or the government even, where the patient is with them for a limited period of time, should be taking on this risk. I think these are wonderful drugs. They should be rewarded, that these pharma companies are bringing out, but the risk of paying for them should be taken on by them, and making sure that they continue providing the sort of the outcomes that they have been promised.
Or what are your thoughts on this conversation so far about the risk associated with some of these drugs and maybe new models for paying for those?
Yeah, so I first and foremost, I think from my perspective, it's exciting that we're even having this discussion about these potential curative therapies. The fact that it, in some ways will like spinal muscular atrophy, for example, which is a death sentence for young children, that will no longer be the case. So I think in addition to, I want to add to, I agree that the challenge we have from a payer perspective is how do you manage the costs that come along. And if you think about, these potential gene therapies and their ability to treat diseases for which, maybe there was no cure, or it managed, you're replacing that with a lifetime, years or potentially a lifetime of therapies or treatments. In theory, there should be a cost savings. So, but the challenge that we are faced with is, the long-term efficacy. We're sort of on the cusp of this. So what are the outcomes down the road? To Robert's point about, I believe in some European countries, there's sort of an exploration of how do you do like an installment plan type of proposal. It's again kind of that value-based concept of paying for outcomes. The other thing I want to kind of point out that this represents too, and when you see this, is it's a total shift in our delivery system as well. It's not just, now we're talking about not just the drugs you get at the counter, right? It's completely shifting how, and so our providers need to be engaged in this conversation. For example, I believe there's a therapy in the pipeline to manage cardiac conditions. So if you think about chronic heart disease and how that's typically treated versus the genetic therapy that is coming online. So we take statins, it'd be a general practitioner, maybe surgeries are involved. Shifting to, if there's a new gene therapy, to totally eliminate your cardiac disease with one procedure, which involves, I believe, the installation of a balloon catheter by a specialist cardiologist, that shifts the care model completely away from managing at the primary level to the specialty care. So we also need to think about payment models and incentivize a shift in our overall delivery, healthcare delivery system in order to really be fully prepared for absorbing a lot of the positive outcomes, but also the challenges with balancing costs that come with these.
What role, Laura, do you think government has in reinsuring some of these products or supporting plans or risk-bearing entities as these come online? My concern is that as they come, they're sort of narrowly focused medicines for narrow populations, but as those rack up, it will just become so expensive relatively quickly. Where does government fit in?
I think there's a role. I would say that it involves a larger conversation. But with that, as Robert, I think, pointed out, it's, we're paying for it somewhere. So if government has a role, our taxpayer dollars are flowing through that, or the premium, or the insurance products that Robert kind of brought up, that innovation. So, I think that given the spectrum at which this impacts, again, not just the payers, not just the manufacturers, the patients, but also the providers. There definitely needs to be a conversation broader with the government involved in that discussion. And like I said, I believe that's kind of some early discussions have occurred in other international markets as well.
Cheryl, I want to move to your slide here in just one second, but I wonder if you have a comment or a thought on the role of government in some of these more expensive drugs. Business groups on health across the country have been calling for much more government activism in a number of spaces. What are your thoughts on this question?
Well, we focus more on the waste issue, and so for us, it has targeted more the PBMs because they make a tremendous amount of money for providing some value, certainly, but they make a lot of money for no services, essentially. And does that mean that we don't go to pharma and say, if you continue to have your drugs be at this certain level, you're going to start seeing employers bail? Because large employers will always probably pay for the new therapies and the drugs as long as they're doing all right. But you'll see a lot of people drop out because they simply won't be able to afford it. So that's why we're looking at different options, including ones I've mentioned, ones that Laura mentioned, and what is going to be sustainable over time. In terms of the government, I think some legislation needs to take place. For example, right now we're seeing, it's a little off-ended, but we're seeing transparency legislation for hospitals to provide the top 300 services. It goes into effect in January for health plans. And so far, a lot of the hospitals are paying the penalties. Nobody wants to be transparent. I'm going to talk about transparency in a second, but nobody wants to be transparent with their prices. So I think we have other things that we need to focus on as well and take smaller steps in this area. I don't think that, I love Robert's idea of, having some sort of a value-based design or outcomes-based contracting. And I'm a believer in getting middlemen out of the way. Everybody has a right to make money, but not so much more for providing less value. So I think drug companies have to be part of this. PBMs have to play a role. Employers will not keep writing checks in the future. So that's my perspective. In the government, we may have to have some legislation.
There's a lot there. I appreciate you unpacking that, Cheryl. Let's turn now to your slide. There's a lot here as well. I want to leave it up on the screen for a little bit so you can talk us through. Go ahead and tell us what you brought to the conversation.
Well, I brought 3 slides and I'm going to go through them relatively quickly. This is our 2021 annual employer member survey on health benefits management, and we're giving the employer perspective on some of the key issues in the marketplace today and what some of the challenges and opportunities are. I'm going to focus a little bit on pharmacy benefits here. You'll see in the top left the top threats of affordability to employer-sponsored coverage. The most significant threats are specialty drug costs. It's been this way for a number of years. We have a number of things that we work with our employer members on. But of course, high cost claims, and that includes medical on the medical and pharmacy side, are second, followed by specific diseases and conditions. And this is relevant, especially during the pandemic, because people did not get needed care. They didn't get preventive care. A lot of people were not effectively managing maybe those chronic or multiple chronic conditions, 4 or 5 different conditions. Even people that had cancer were not getting care. So they're concerned about that. The pipeline for high-cost gene therapies comes in there, and most employers aren't even aware that that pipeline exists. If you're a member of a coalition, you've likely been informed about this, and you're doing something about it. And then I mentioned lack of transparency earlier. I'm going to jump down to waste, inefficiency, and low-value care, and we did pass some legislation recently on surprise medical bills, so that's exciting. On the far right side, what are some of the top payment reform strategies that employers have currently implemented or plan to address? Again, specialty drug management comes in at number 1 in terms of employers that are looking at this. And we represent mid, large, and jumbo employers in the Midwest. And so we tend to probably have more progressive employers that are doing things, but the learnings from what they're doing translates to employers across the country. I'm going to jump down to the bottom of that slide, and you'll see that about a third of employers are truly looking at how they're going to reduce waste. I always say if we could reduce waste in appropriate low and no value care, we could save 30% of the healthcare dollars. And that's one of the things I'd love to have us focus on. I'm doing that in a handful of ways. And then we're also looking at price transparency. To kind of get us back on track, you'll see at the bottom, in terms of the pharmacy benefit strategies that employers are focused on, this isn't the whole list. I wanted to share with you the ones that I think are most relevant. 63% of our members are optimizing their PBM contract terms. And this is the number one thing we tell employers that they need to do. Because right now, most PBM contracts benefit the PBM, not the employer. So you really have to change your contract terms to make sure you're covered. And by the way, employers, doesn't matter if you're fully insured or self-insured, you are fiduciary. You are responsible for getting the best benefits at the best cost for your employees and family members. And then you'll see biosimilars on formulary. A couple of years ago, even a year ago, this was in 24% of our members were currently offering biosimilars on formulary. We've been trying for 8 years to have this happen. So for us to see that 63% of our members are finally doing it makes us very, very happy. And we've got a couple projects going on as well in that area. You'll see transparency in here, and then you'll see custom formulary and carving out specialty drug management. So in addition to the contract optimization and having a custom formulary that gets rid of the bad drugs or the low value drugs and focuses on efficacy and not rebates, which is something that PBMs do. That's what you're paying for, so that they can take those rebates and hold on to some of them, or spread pricing, or some of the other things that are happening. And then carving out those drugs from the PBM, you have a better ability to manage it. The only other things that we're working on related to that are employers doing direct contracting. They're kind of unbundling the PBM and then putting the pieces that make sense back together, which is kind of the way it should be. Direct contracting with retail pharmacies. And then we're working with an academic institution, School of Pharmacy, that works with some jumbo clients in offering drugs for 20 disease states. And they pass all the rebates back to the employer instead of getting the middleman involved. So we're going to be offering that to our members in the near future. So we're active. We're active in the Midwest. We're active in the state of Illinois where we're located, and we're going to keep pushing forward in these areas. Thank you.
So, Laura, in a previous life, I would have said that employers, like health plans, are firstly focused on managing things like congestive heart failure. I would not have said the number one area of their focus was specialty pharmacy. What do you see when you see this? Anything jump out at you as a surprise?
No, I think, again, in a previous life where I worked with employer groups, that the discussion was around general costs and managing costs for particularly chronic disease, but specialty wasn't even in the top 5. And that was just 10 years ago. Now it's the top concern. And I think, I don't know that, with respect from the payer perspective, and when you get down into, and I represent the insurers that also serve the smaller fully insured market, so individual and small group, where you have, I can tell you that at least in the state, and I focus in on Illinois, the number of legislative and items that come before and attempt to kind of put restraints on the insurer as far as the benefit design, it's all designed to go to prescription drug costs. And we could probably spend an entire discussion on, the concerns we have with that piece of it, but it definitely is across the board. And I think this goes back to our whole point of this conversation, which is, how do we balance the expectation, particularly around the outcomes associated with these specialty medications, with the stress that we're all facing with what does this look like from a financial standpoint on everyone.
Robert, and forgive me if maybe Laura or somebody else is the better person, or maybe nobody's the better person to ask this, but I'm just wondering from a clinical perspective, it doesn't seem like there's much you can do in the way of care coordination to manage specialty pharmacy. Like, specialty pharmacy is it is a RX, it's a prescription for a specific diagnosis, and care management is not going to mitigate that utilization or efficacy very much. Is that accurate?
No, actually, I disagree. I think that specialty pharmacy is where you really need care management to make sure that the patient is taking these medicines, because remember, these are extremely expensive medicines, but they're also life-changing medicines. So we do need care management in this case. And the more care management has shown, especially delivered by pharmacists, has demonstrated that the patients are more compliant with their medicines and there's a reduction in overall healthcare costs. But unfortunately, because we have a siloed system in this marketplace, in the healthcare marketplace, where we pay for everything separately, we don't necessarily always look at the bigger picture. So care management absolutely is necessary in this market because, first of all, there's limited number of patients. It's only a few patients that take these medicines. If you look at the volume, it's small, but they're extremely expensive, but they're also life-changing. So those are the interventions that we need to remember. Healthcare costs in the United States are being driven with a very small number of patients. About 10% of patients drive about 80% of the healthcare costs in the United States. So if we are able to manage these 10%, we can do a lot of work in denting the healthcare cost curve. Unfortunately, because of the siloed system that we have in this market, we are unable to see this or be able to accomplish this appropriately.
Good. I appreciate you righting my listing ship, as it were, on that one. Laura, let me ask you, let's turn to your slide here. I know you've got a lot going on as well on this slide. Walk us through it.
Yeah, so I think first of all, just trying to level set a little bit with the insurer role. And Cheryl mentioned PBMs quite a bit, but the PBM is a partner that works with the insurer, particularly to manage a very complex pharmaceutical supply chain. And from the insurer perspective and the payer perspective, it's balancing, like I said, efficacy, access, and affordability, and kind of this whole concept of insurance, which is socializing risk. You have to socialize it amongst your healthy, those that have rely heavily on pharmaceutical spend versus those that may rely more on non-pharmaceutical services. So I, with respect to this slide, I borrowed with permission from the Pharmaceutical Care Management Association. I think for the graphic perspective, really I was trying to demonstrate what has already been said, is that, and Robert pointed out that, as you go through, generics are obviously represent the most significant or highly utilized drugs in the market. They have the lowest cost. Then you go to brands and you see a significant drop in terms of this presents it as claim, but even across your population, you have a lower population that is relying on the brand specific drugs, but they represent a higher percentage of costs across your entire insured population. And then obviously, as we've spent a lot of time and we'll continue to talk about specialty medications, that number decreases. I think if you look at a population of 100,000, anywhere less than 4% at most is going to be those that rely on the specialty medications. And they represent the most significant cost, as Cheryl was talking about, sort of the stress point for all of us, all payers, not just employers, but even public employers as well, public programs. And I think what's key is that, what PBMs, and I know we talk about the role that they play in negotiating prices, and we'll spend a little more time on that, but it's important to also note that, they serve a necessity in the market in terms of what else they do in this space. I mean, claims processing is a big part of that. I mean, think about how complex the supply chain got. And they evolved, I think, in the early 80s for the very reason that you could no longer afford to rely on a paper-based system. But they also, to Robert's point, I absolutely 100% agree that, once you get into that specialty medication area, you absolutely need, disease and chronic disease management and adherence in order to ensure that truly you are realizing the efficacy of these drugs, because they are so high cost. And with that, you're moving into a more specialized pharmacy related place. You have, most of these are, I would say not all of them, but many of them not only reflect in your pharmacy benefit spend, but also in your medical spend, because they're delivered intravenously. So you have physician administered drugs. So that's a piece of it. I mean, it's reflected on your medical benefit expenditures as well as your pharmacy benefit expenditures. And with respect to the other aspects of this, I mean, benefit design from the insurer's perspective is a key part of this. As I mentioned earlier, we represent insurers that that serve a multitude of payer populations, not just the large employers that have a lot more flexibility in how they design, say self-insured that, know their risk population, know who they're serving, and can design, contract with the insurer as a third-party administrator and contract separately with the PBM as a third-party administrator, or negotiate with those two entities to design a package based on the population they represent or they have a fiduciary responsibility for. Once you get into the state-based marketplace and those that are regulated at the state level, your benefit design opportunities get a little less flexible. So you not only have the ACA benefit requirements that are very important, but in states you have your own very specific state coverage and regulatory requirements that can sometimes be very restrictive. So when we talk about managing costs effectively, there is a bigger challenge, I would say, in the fully insured market, particularly because we tend to face a lot more of the state regulatory restrictions, that again are designed to benefit the patient, but sometimes the policy doesn't have the best outcome for the entire population.
So Cheryl, Laura's making, I think a well-reasoned and well-received argument that, if the PBMs are a necessary piece of this puzzle, and if they don't do it, it's awfully hard to control costs and get a handle on some of these drugs. What are your thoughts and reactions to what Laura said?
I think that the PBMs intended to do the right thing, but I think that over the years they figured out a way to make a lot of money. And I'm really talking mostly about the top 3 PBMs that have really dominated, 80+% of the market. And if you look at the chart, I think everything that Laura has said is true. The problem is with PBMs that once they, let's say, were found that they were keeping more of the rebate that they should have, and I've got a list of 7 things that PBMs do. When they get too much pressure on one area, they just push the balloon in another area. They don't want to make less money. And so, specialty pharmacies came to be because the PBMs often were not managing specialty drugs appropriately. So it's just like the wellness industry cropped up because health plans and insurance companies were not effectively managing the lifestyle risks and chronic diseases. And I'm not bashing any one stakeholder. I just know that we see a lot of overpayment for things that shouldn't be. So I have an obligation representing employers to bring that out and figure out ways to work around it. And in terms of the role of insurers and PBMs today, they've merged. We know who has bought out who, and now they have a very solid foundation for not necessarily changing what they're doing. I find them to be less transparent than they were 5 years ago. And I still think, generics and brands, most of my members have those under control. Many of my members only offer generics first. We're not talking about specialty, but traditional pharmacy generics, and then they only cover brands that are not covered by a generic. When it comes to specialty on the pharmaceutical manufacturer side, we're still waiting to get information about which is most efficacious. That's not happening. Nobody's doing that in the market, not the PBMs, no one. And again, we still see that PBMs are choosing drugs based on how big the rebate is. That's another whole program if you want to have it. And so when there was heat around rebates, they just changed it to be administrative fees. We're trying to get down to the net cost of a drug, and then we'll pay you an administrative fee. But our model, as I talked about it earlier, is where I see the future, where we're unbundling the pieces that the PBM probably shouldn't have had responsibility for, putting the model back together, and employers are seeing significant cost savings. That's where we'd like to see the future go. There might be a percentage of the employer market that will always work with PBMs. I hope that they morph themselves to be more of what the marketplace needs right now.
So Robert, as a self-identified economist, let me ask you this question. At the end of the day, and we'll move to your slide here momentarily, but at the end of the day, isn't this conversation about specialty drugs the same conversations that held in other places about specialty hospitals or specialist providers? In other words, where you have perfectly inelastic supply of one monopoly provider and perfectly inelastic demand of a parent or somebody who will pay any price or do anything they can to take care of their child, isn't that just essentially a market breakdown requiring some other approach?
Yeah, absolutely. There's a market breakdown because you have three PBMs that control 90% of the market, basically. So if the consolidation has created a market monopoly, and I would say that PBMs should exist and they should work with employers. There are PBMs that do the right thing. Costco is being one of them. Capital RX is another. I'm an advisor for Capital RX. RX Paradigm is another one. That is, these are all transparent PBMs. They have one set of books instead of two sets of books. They can be audited anytime that the employer wants or the government wants. And the only thing other than that, I would say that gamesmanship in pricing and sort of profit taking happens not only specialty care, but also in generics. I'll give you one example in the generic space with spread pricing. So the Schaefer Institute at University of Southern California partnered up with Costco, and they did a study looking at Medicare. What happens to Medicare if they took the 200 highest prescribed drug in generic market in Medicare and just had the patient pay for it in cash and go to Costco and pay for cash? Over a 2-year period, the Medicare program would have saved $4.5 billion. Billion dollars. Just, it will be cheaper for Medicare, in other words, instead of using the insurance program that they currently have through the Part D to buy membership for Costco for all their members and just pay for cash. So those are the gamesmanship that happens in these markets. And it's not just the specialty drugs, it's also in the generic market and in formulary design, which includes both of these things. And I'll go through it when I go through my slide, how these misaligned incentives exist.
Mhm.
And so my answer to you is that we need to be aware of this, just the entire pharma market and how the gamesmanship is done. That doesn't mean get rid of PBMs, but go with PBMs that are willing to open up their books, give audit rights to everyone, and they allow 100% transparency. And what Cheryl said is absolutely true, that the programs and the stuff that they provide to employers or to the insurers as well, because insurers also work with the PBMs, is based on a set fee, not a percentage of a rebate or a percentage of a fee or something like that they retain.
So I want to ask Logan Jackson's question after you introduce your slide here in a second, Robert, but I want to make sure I understand one thing you just said. And this is not exactly what you said, but let me pose this and sort of restate what I heard, which is, it seems like, I think you said effectively that if we had traditional Medicare paying for pharmacy via Costco and cash payments, we'd save $4 billion plus. Is that saying that the Medicare Advantage program is providing so little cost control that there's a $4 billion benefit to moving to a cash-based model through traditional Medicare? Is that an implication of what you're saying?
No, the implication is in the fee-for-service. So these are the Part D PDP programs. So what happened is that Costco basically, what USC did is took a look at top 200 drugs that are basically dispensed through Medicare and said, and they have volume also for those drugs, how much they were dispensed, right? So they said, of these generics, they're all generics. What happens if those pay, instead of what Medicare ended up paying through these PDP programs for reimbursement, we just purchased these drugs through Costco in those years. And over 2 years, that's what the $4.5 billion saving was. That's just on the generic space. We're not talking about specialty medicine, brand name medicines, or anything else. This is just literally, instead of going through the insurance, going through and walking to your Costco and paying for it in cash.
Got it. Thank you for the clarification. I want to tee up your slide now, Robert. Go ahead. Sure. You've got a lot here. Take her away.
Yeah. And I want to talk about misaligned incentives. And the reason that misaligned incentives are important to me, besides being bad for the entire healthcare system, is because it impacts patients. And the reason being is that in the arena of pharmaceuticals, that's the only entity in the marketplace that patients end up paying based on the gross price or retail price of the medicine when they have a coinsurance or a deductible, versus in any other entity. I'm going to my optometrist later on today, and when I purchase or have a service with the optometrist, it's a percentage of a negotiated fee. So for some reason in pharmaceuticals, the patient ends up paying the retail price as a percentage when they have a coinsurance or deductible. And this is important because the misaligned incentives create a marketplace that the patients are overpaying for their prescriptions. So my slide basically looks at Express Scripts 2022 formulary. And this is important because formularies used to be, when 20 years ago, 30 years ago, 40 years ago, that they were designed, was based on cost, efficacy, and safety. Now it's basically to maximize rebates and fees for the pharmacy benefit managers. And this is just two examples. I'm doing more extensive research of looking at both Express Scripts, Optum, as well as CVS Caremark's formularies for 2021 and 2022, looking at where there are discrepancies when they are basically saying, let's go with a much more expensive drug on a retail space versus a much more less expensive generic, or in this case, authorized generic. So the authorized generics are basically generic products that have a different NDC code, different pricing, that have been introduced by the same manufacturer. So in these two examples, Gilead basically has put out, I believe Gilead makes Exclusa. I know Lilly makes Humalog. In these two cases, the manufacturers have put out authorized generics, which are basically the same drug. It just has a different NDC code. And in both cases, the generic, authorized generic, is disfavored. It's basically blocked on the formulary in favor of the brand name medicine. And the cost differential is between 70 and 230%. So if somebody from the PBM industry can explain this to me, of why this is happening in the marketplace, I would be very glad to hear it. They used to do this 2-3 years ago, as Sharon mentioned, with biosimilars. You saw biosimilars basically being blocked on formularies in favor of brand name medicines. And we knew clearly that those brand name medicines were much more expensive on net price because we had ASP prices for them. So it's disheartening to see this. And I will point out to the two studies in the below part, which both of them were funded by the Arnold Foundation, which is not a industry sort of supportive organization, but good for them that they funded these studies. In both, one of them basically showed that in 72% of Medicare Part D formularies, at least in one case, a multi-source generic was blocked in favor of a brand name drug, which makes no sense, right? These are small molecules that have multiple generic equivalents available in the market, but the generics were blocked in at least one case in 72% of the Part D formularies. And then the second one has to do with biosimilars, where a lot of hospitals were blocking biosimilar usage in favor of the brand name medicines, and they were not even included in the formularies. Again, this has to do because of gamesmanship that happens with rebate maximization and fees, which again, remember, fees are attached to the retail price. So as soon as you get rebate contracting, you get fees involved, and it's a percentage of retail price. And that's what I'm saying. We need to go to a transparent system where the fees are set, there's no gamesmanship, and the books are open and auditable by everyone, including the federal government, which is very disheartening right now that they're massively pushing this major policy issue on the federal level, utilizing data from 2016 based on testimonies and rather than real actual data. That's because the federal government lacks audit rights.
Lacks what rights?
Audit to be able to audit the books of the PBMs.
So Logan Jackson has this question. He says, it seems that PBMs are effective in that they reduce prices for patients, but as the panelists have said, their power over the RX process is often blamed for the increasing cost of medications. How can we ensure PBMs are still playing this key role of reducing costs for consumers while also making sure they aren't taking advantage of rebates? Laura, do you have any thoughts on how to amplify the cost control power of PBMs while, as Logan asks, while they may be disallowed from taking advantage of rebates?
Well, first of all, I feel that I need to respond a little bit to the rebate conversation or negotiation piece of that. I think from an insurance perspective and how it's socialized, and there are different PBMs that approach us differently. There are some PBMs that offer the point of sale type of discount. So for a patient that relies on a brand medication, for example, that is subject to a rebate, at the cost sharing that they may see as a point of sale, that rebate is passed along at the point of sale, for example, that will benefit that patient. For those that do not rely on that, and those are socialized across the premium, so it represents a premium savings. And I think there are opportunities, and I with Robert's slide here, this is just one of many different variants of formularies that I know Express Scripts and others have, where they have different flex formularies. There are different options available, again, for employers, particularly that self-insure their benefits, to negotiate different formulary options based on the populations they serve. Again, there's a lot more flexibility in the self-insured market than there is in the fully insured market. I will grant that. But I think too that just to kind of also expand this a little bit, there are misaligned incentives across the board, and I am not here to argue that transparency is an important role in across all boards. I think that that's from the consumer perspective. Healthcare is one of those few things where we spend a lot in healthcare with the consumer really doesn't understand what costs are going into that. Whether you're a private pay, the price point you pay from the hospital perspective is far different than if I'm on Medicaid or Medicare. So I would agree that transparency is important, but if you want to talk about misaligned incentives, there's also misaligned incentives and kind of the how drugs even come to the table. And there's regulatory provisions that I think protect to some degree brand products, exclusivity periods. Cheryl mentioned the Orphan Drug Act, which I think unfortunately has been gamed a little bit in terms of keeping brands on the market that were designed, brought to market for the patent that, were to treat a very rare disease, but now are treating, very common diseases for which there is multiple medications available. So that is not a conversation in Illinois we can change. That is something the federal government has to look at. But I would also say, going back to the state level and my comments about because I'm very state focused, we also see this with respect to the pressure points of, consumer groups that definitely want the brand medication. So we have language, we have laws in our state that require the insured populations to cover all FDA approved substance use disorder drugs for generics and for brands on the lowest cost tier. Well, that's regardless of efficacy and outcomes. There's no flexibility to do that. In addition, there's also provisions we have in place to require that drug coupons that are often given to to help reduce the out-of-pocket costs, particularly for those that on high cost specialty medications, brand medications, those apply towards the deductible and they accumulate towards the out-of-pocket costs. Well, again, it misaligns incentives with trying to drive customers to lower cost point of sale products or drugs. I would also just note there's a healthy amount of consumer education that needs to go in this discussion. I totally grant that. For example, in Illinois, we have a law that says, if I go to the pharmacy counter, the pharmacist can inform me that what I would pay had I not had insurance might actually be lower than if I get insurance, and then it applies towards the benefit. We support that. It should be the consumer driving that discussion. Unfortunately, not a lot of consumers are equipped to be in that driver's seat, and they very much should. I mean, we support that they have a better understanding of what their options are when it comes to reducing their out-of-pocket costs.
I'm sure we could talk about rebates for a while. I know we've got a lot of thoughts on this. So let me pause here for 1 second, ask this other question from Jason Smith. He says, I was wondering what role you see state-based prescription importation programs playing in this discussion, especially with states applying to import prescriptions from Canada. These programs, generally speaking, apply less well to employers because these are often Medicaid-led programs. But Cheryl, I wonder what your thoughts are on being able to import drugs from out of the country from Canada for your employers or other payers.
If I asked my employer members what they wanted to do, they would say we need to fix the system in our own country, number one. They also are concerned about safety and quality, and it is not that the drugs from Canada wouldn't be safe and have good quality, but there'll be a bunch of middlemen and women that will be in that process as well. It's just like international versus domestic tourism. If we can't send somebody to someplace in our country, we need to rethink how we're doing it. I would say that there are going to be some employers out there that are going to get behind it. I know some of my sister coalitions in other states have employers that are ready and willing to do it. In our market, we represent a lot of large national employers, so they would have to deal with it across the country. It's not just a state-based thing. So I would suggest that we need to focus on addressing issues in our state and in this country.
I want to migrate to our final slide in this conversation and recognize that we're getting a little short on time. This is one that we've brought into the fold, thinking about the sort of changing nature of biologics and biosimilars. That's something that we've mentioned or danced around here with this conversation. But as biosimilars come to market and provide increased options for patients who have otherwise been using biologic drugs, these are the large molecule drugs that take a biological process to develop and create. They're very expensive. And as biosimilars have come into the market, they have fundamentally changed the pricing. They've changed the nature of access for these drugs. And this is just a product of time. There's a direct policy implication there, as we've talked about, sort of change and shift in biosimilars here over the last few years. But this is a slide that gives me some hope that even if policymakers can't get all their ducks in a row, that the market sooner or later will lead to the right thing. So as we near the end of our conversation here, I want to ask each of you this question about what gives you hope in this space in terms of health reform in general, about the work that you're doing. Cheryl, let me start with you. What gives you hope as you think about healthcare and the direction we're heading these days?
Well, I'll focus for a second on biologics. Look at how long it took for us to get generics to be accepted. It was a long time. Biologics, it's taken us far longer than we expected. There were a lot of reasons behind why biosimilars were not accepted. So it's exciting, as you saw, that 63% of my members have biosimilars on formulary. In terms of the direction we need to head, I think we need to start out looking at the transparency efforts and looking at unbundling that PBM model that has so many employers across this country in a stronghold, and watching the direction that the balloon goes. Listen, we just want to be partners with the key stakeholders out there, so that we can say, you have a right to make a certain amount of money, but you cannot make an unequal amount of money against other partners. And I could talk for hours about this, but I will stop at that.
Robert, how about you? What gives you hope as you think about the direction we're heading in health reform these days?
Three things. Number one, the biosimilars. So the best example of that competition, as an economist, competition works. When you bring products into the marketplace that are competitive, they do drive down prices. That's economic theory 101. And all we need to do is get out of the way. Basically, this is what it tells me for biosimilars. Now, biosimilars are going to be on the docket in 2023 because the largest biologic by far in the United States, which is Humira, is $16 billion in sales in the US, is going to have 6 approved biosimilars coming out in 2023. So we'll see what happens in this market, because if we get that correct, there's going to be significant amount of savings that we can incur by just having biosimilars replace the originator biologic and drive the prices down. Whether they replace it, but just prices down. Second thing, we're talking about transparency. We're having a discussion about how the supply chain is working. We're having employers asking the questions. And the third thing is that we need to keep the PBMs, the pharma companies' feet to the fire, the PBMs with more transparency, no more gamesmanship with rebates and fees and everything else. But with pharma companies, they need to come clean. They need to be very upfront about how they set their prices upon launch of these products. They complain about organizations like ICER, who's basically doing the price setting for them. But at the same time, they're unwilling, and I know this data exists within the bowels of all pharma companies, of how they come out with these prices initially. And they need to be transparent about it and then explain it to the public. It's no longer acceptable for them to say, this is what the market bears. No, tell me exactly how you came up with X price. We're all adults, we can figure it out. But the gamesmanship needs to end. the transparency needs to be applied to the marketplace, and more transparency, less gamesmanship on all the sides will benefit the patients.
Laura, we'll give you the last crack at this question. What gives you hope as you look at health reform in general, particularly in Illinois?
Yeah, I fully agree with Robert's comments about, transparency and stopping the gamesmanship, also on the pharma companies as well. But I think more than anything, what this slide demonstrates, and just the fact that, yes, you're right, competition. We don't see this a lot, and this is a discussion with other types of small molecule drugs where it's like the inverse, right? So more competition comes in, the price continues to increase. This actually demonstrates that the price is decreasing and the per unit price is coming down for all of these drugs that have, not to knock the small molecule drugs, but have a lot more opportunity for improving health outcomes, but if we get it right. And again, I go back to my point that it doesn't just involve the discussion with the three of us represented here, it's also the provider, it's the patient, because a lot of these biosimilars, especially medications we've talked about, really do involve the entirety of the system and the entirety of the healthcare delivery and an engaged consumer. So I think when we talk about healthcare, that's just transparency, but healthcare reform, it's how do we get consumers more involved in their healthcare decisions, like employers are, but the actual individual consumers.
Laura Minzer, the president of the Illinois Life and Health Insurance Council, Robert Popovian, the senior fellow for health policy at the Progressive Policy Institute, and Cheryl Larson, president and CEO of the Midwest Business Group on Health. I appreciate all of you joining us, and attendees, I appreciate you guys being with us. We'll have this show up on our site at stateofreform.com. I want to also say good job, Alex Nelson, producing his first show on our back end, and thanks to Ethan Kispert. We'll have more of these conversations in the future. Thanks for your support, everyone. Take care.